Thank you for the kind introduction, Sabine, and also thanks to the organizers for inviting me and giving me the opportunity to present to you today the work that we are doing in the Swiss Personalized Health Network all around verification of routine healthcare data, but also other health-related data types. So this is truly a home game also for me today. Not only has this conference chosen the venue, the beautiful city of Basel, which I call my home, but also I have with me in this first session our data interoperability team lead, who actually deserves most of the credit of the content that I will present to you now, of course, together with her team and the experts from our network. I think we can agree on two things. The first thing is that we cannot improve a quality of care without the significant contribution of research and innovation. And the second thing is that given the vast amounts of health data present already now in the healthcare sector, we should no longer take decisions in the healthcare based on purely population averages, but should take into account individual patient characteristics. But to figure out what kind of individual patient characteristics we should actually take into account, we have to run big data studies. So we try to gather data from a lot of patients, but ideally also of healthy cohort populations, and use them for data exploration, for detecting new signals and finding new correlations, to come up with new research hypotheses that then, of course, have to be tested in control, hopefully randomized clinical trials, to be proven causal, and then to, of course, yield the goal that we are all striving for: more precise diagnostics, prevention, prediction, and also treatment, and overall improve the quality of care. When we look at the different health-related data types, there are many of them. Nearly everything can be related to health. You know that, starting with the biology side of the omics data, genomics, transcriptomics, proteomics, and so on, the metabolites, also immune system, biomarkers, the microbiome, but also this middle part here, the most important one currently, at least for SPHN, is data from the routine healthcare settings, so EHR, electronic health record data, but also, of course, images. And when we go further down, also wearable data play an important role, not so much in the focus of SPHN, sensor data, and of course, the environment has a large impact on our health. The first requirement for the successful development of multimodal data-enabled application, not only application, but also, of course, if we would like to start with that personalized health research sector, is the collection, curation, and harmonization of well-phenotyped and large annotated data sets. And now there is the best part of that sentence: as no amount of technical sophistication can derive information not present in the data. And this really often gets forgotten, right? We assume that we can just use health data as it occurs, but we can't. We have to put a lot of work into making data usable for research purposes, but also for other secondary usages. There are a lot of initiatives on a national scale in many countries to establish such large, well-phenotyped, curated data sets. You know them all. It's the All of Us or Biobank, or also microbiome, omics, the MIMIC data set from intensive care units. We also have prominent ones in Switzerland, for example, the Swiss HIV cohort study or the cohort study on transplantation health. The characteristics of those data sets is they are curated, they are specialized, and they are harmonized, intrinsically at least. They are normally done from a prospective perspective, so it's a prospective patient recruitment, but also prospective data recruitment. And they have directed criteria when it comes to, on the one hand side, the inclusion or exclusion criteria for the patients or the population, but also when it comes to sample or data collection. So All of Us is mostly genomics, and then the microbiome is microbiome, and the omics is on other omics data. MIMIC only looks at intensive care. So when we, of course, use this data within these curated data sets, that's all fine. It's interoperable intrinsically, at least. But if we would like to mix and match at a certain point, this might be more tricky. First of all, with regards to data interoperability or linkage. But second of all, also in terms of governance, I assume. Then there are other national initiatives working on the roots, actually, of data sources. So it's not about the creation of a specific data set, but it's fostering the secondary use of health data in general, right? To prepare data to be usable. They tackle data interoperability aspects at the source. They strive for data linkage, not only on the individual level, so adding new data elements on one individual, but also gathering more individuals into different kinds of projects. They address the fragmented data ownership and governance issues, because if you derive data from different sources into different projects, you have to, of course, deal with a lot of different data owners and different models for in terms of data governance. And they have an impact on existing data processes. So when you think of the way how data is captured, for example, in a hospital, or how data is used to feed registries, or if we think of new reimbursement approaches, when we think of, for example, pay-per performance or so on, we can influence with these kind of initiatives, we can give an influence to all of those processes all around the healthcare setting. SPHN is such an initiative that likes to tackle the problem at the root. And when we look at the personalized health research challenges, I listed particularly the Swiss challenges, but I assume they are also valid for many other countries around the globe. We want to recruit routine data from a clinical setting that is actually captured for care, not for research purposes. This is complicated, right? There is a big difference in data capture for those two approaches. The quality of care is an issue. Here in Switzerland, at least, unfortunately, our data reflects more the reimbursement, the billing reality, than it reflects the health status or the sickness status of a patient. We need a critical mass, especially in a country like Switzerland that is very small. We need to collect a lot of data from different sources to be able to come up with a critical mass. And these sources are truly scattered around the country. We have 26 cantons in Switzerland, and the cantons are in responsibility of the health aspect. So this means we need to deal with a lot of in-country boundaries, if you wish. Also, the genomic basis, at least in the clinical setting in Switzerland, unfortunately, is widely lacking. Genomic medicine is only at the beginning in Switzerland. And also we missed our chance in setting up a broad genomic initiative in the last 20 years, as other countries have done, for example, the All of Us, or also the Genomics England and others. Health data is sensitive data, no matter how much we anonymize them or pseudonymize them. If we not truly anonymize them by aggregation, they remain sensitive, right? The sheer amount of information you have on one patient when you look at his or her journey through a hospital always provides the possibility to re-identify this person, no matter if you strip the name or the birth date or the address. So we need to deal with that when we want to make health data usable or reusable for research purposes. And of course, we have to look at the ownership aspects and governance aspects. And ideally, we would like to come up with streamlined approaches here, because if we want to gather data from multiple sources, we do not want to start from scratch every time to discuss or negotiate the conditions under which we are able to use it. So Switzerland is a federal country, and we truly believe in decentralization. So we like to keep everything at the source and work together with those institutions to come up with high quality data at the source. We have as a main collaborative partner in our network, the 5 university hospitals of Basel, Zurich, Bern, and Lausanne and Geneva, together, of course, with their universities, the 2 federal universities, many different technology centers that were set up in the realm of our sister initiative. This is the Personalized Health and Related Technologies initiative of the ETH domain. We gather also partners from the clinical research setting in SPHN. Also funders, is very important to have funders on those boards. So this is really a collaboration of unprecedented scale. And this is necessary because personalized health is a interdisciplinary field. We need many different data types from different data sources. We need hospitals as data providers. We need research institutions as data consumers or as data users. We need, as I said, all of these specialized technology centers. We need help when it comes to data science approaches. We have with the Swiss Data Science Center and also the SIB all of these partners around the table. And we also basically embrace these regional and local initiatives that there are in Switzerland, like the Loop in Zurich, for example, or the Health 2030 in the Lac Léman area. So we try to bring all of them on one table and come up with good solutions that span the entire country. The aim of SPHN is to create a scalable and sustainable data enabling environment, including different types of health data. As I said, we are funded by the Swiss State Secretariat of Education, Research and Innovation with 135 million francs for 8 years. We're already 3/4 into the initiative. And the entire network operates under one common ethical framework, which is important that everybody commits to this, because this basically sets the ground on how we want to collaborate on health data. We want to enable institutions to responsibly share interoperable health data. We don't force them to share them. We only want to help them make them shareable. There's a big difference. And we would like to enable researchers to access, integrate, and analyze the data. Here you can see an overview of all the infrastructural parts that we have set up in the last 5 years, services and support. I will go into detail, some detail regarding the clinical data platforms that have been set up at the university hospitals. But also we have the Biomed IT network on the other side. This is a trusted research environment that we set up in the responsibility of the Swiss Institute of Bioinformatics, like a cloud infrastructure spanning 3 high-performance compute nodes. And this is our environment that we use when we gather data from those multiple sources, bring them together for research projects. They remain on the Biomed IT network in this secure IT environment. And this is a very important argument towards the data providers. Right? If you have technical, but also operational, but also administrative measures that protect the data from ending up on a private laptop, left on a train, unencrypted. So this is really this makes a difference, right? Other countries now also came up with these kind of trusted research environments, because it's so much easier to argue about the legal framework, for example, the data transfer and use agreements, all those legal contracts that you have to go through in terms of usage is so much easier when you say, okay, and the data is not given out of hands and then maybe given out of other hands, but it remains on the secure network. We also would like to provide researchers the possibility to find the data, to discover the data, and to explore the data. We have different tools or solutions in place for this, but I would not like to stress this too much today. I would really like to focus on the SPHN interoperability framework in terms of our efforts of verification of data. When we look at the journey of a patient through a hospital, we have lots of different data elements or data types that are captured in, let's say, very heterogeneous primary source systems, also scattered across the hospital. And in order to be able to not only use them for the primary use, so for the treatment of the patient, but also make secondary usage of it, we need to integrate them into clinical data platforms. And this is what we have done, what our partners at the Swiss University Hospitals have done. And they have set up these clinical data platforms in their hospitals, did this complex data integration. And of course, it's also important, the implementation of the standards when you think of the semantics and of our interoperability strategy that is being done on those clinical data platforms. Sometimes a bit downstream the process, would be nice to have that more upstream the process, but we're working on it. So these clinical data platforms are basically now providing the possibility to search for data, but also to reuse data for primary uses also. So we have a lot of operational use of health data in hospitals that was not possible before we set up those clinical platforms. But for clinical care, for example, tumor boards would be an example of a primary usage, but also quality control, patient safety, and so on, operational uses. But of course, we can also tap now into these platforms for secondary uses, for research, in-house research in this individual university hospitals, but also, of course, for data that is then being used in the realm of SPHN, for example. But also this is very, let's say, forward-looking when you think of feeding of registries where you have data that has to be submitted to authorities. Of course, these clinical data platforms should also add to these processes so that we can streamline them and basically save resources on other sites. The need for data interoperability is obvious, right? So we need to bring data, we want to bring data together from the clinical routine setting. Here we have to already look for interoperability of those different data elements and data types. But of course, we want to combine them with other health-related data, as I said before, from maybe clinical trials, from registries, from patient-reported outcomes, sensor data, medical imaging, but also, and very importantly, omics data, right? We would like to integrate genomics with proteomics and metabolomics, put the phenotypic data on top, and really have a large stack or a deep stack of information where we can derive information or exactly this kind of signal detection or correlation detection that I was mentioning before. To make sense of data and adding value, our SPHN interoperability framework has basically three important pillars, or basically two important pillars, and then a very flexible pillar at the end. The data semantics is the most important pillar. So here we use controlled vocabulary for concepts, for value sets. We want to standardize data. We have all of these ontologies or classifications or terminologies such as ATC or SNOMED, you know them. We use the semantic web technology for our as a language for our knowledge representation. I guess this is the reason why we are here today. And also we have a quality control framework with semantic web that allows us at the hospital side, at the data provider side, but also at the research side to really exploit the beauty of that RDF presents and the health data graphs in general present. Also, we have the feeling that we reach the FAIR criteria, and with this I do not mean the capital letters, but the sub-principles of FAIR with this strategy the best in order to really come up with fair data sets that can then be sustainably and scalably be reused in the research setting. So this is how our data set looks like. You have the SPHN concepts, and you have the attributes, and to come up with such a concept definition, we reiterate this many times with our partners in the network from, of course, looking at those concepts from different needs, from different perspectives, so that we then finally can come up with a concept that where everybody says, okay, this works for us. We can reuse this concept for our next study. We try, well, I tell you that later. The second part is the RDF schema, where basically the SPHN concepts and external terminologies are RDF encoded for facilitating the transport, the sharing, and the exploration of knowledge. The data providers, our Swiss university hospitals, are they comply with the SPHN RDF schema and are able to deliver health data to research projects in this kind of fair manner. And at the end, this is the flexible third pillar that I mentioned. We are able now to use this RDF data that conveys as much information as possible from the moment of where we get the data from the data capture to the research projects, and can be, of course, transformed into whatever you want it to be into different data models. You can use it for research project, but also use it for other secondary uses. And we wanted to have this flexibility of not committing to one data model, which other countries are doing, or one specific other format, because we believe in the flexibility of RDF to be really the best exchange format that we can have in terms of feeding all of those different use cases at the back. We put meaning binding to our concepts. So this is implemented via all equivalent classes. 47 out of 63 of our SPHN concept have this meaning binding in SNOMED, for example, already now. I'm pretty sure the numbers are higher because we have a new release coming soon. Also, we do that for LOINC wherever possible. Sorry. We also do value set binding. So either we have specific value sets, so distinct and selected numbers of SNOMED codes which are allowed to be used, or we have a general value set, so entire or multiple even subgraphs as possible values that are allowed. And also here we have many of our value sets already bound to specific SNOMED value sets, which helps, of course, also in terms of then the harmonization. The RDF allows inference thanks to the use of terminology. So I present to you here a very simplified example. So these ontologies, such as drug codes like ATC, add information to the data, right, through their classes or through the hierarchies of their ontology structures. The machines understand these machine readable codes and they can infer knowledge. So basically they can reason and say, here is this example, patient 1, 2, 3 were treated with 3 different medications, and thanks to the ATC code, the computer knows that 3 of them are antithrombotic agents, but the 4th one is not, although this is nowhere written in the data, right? So we add information to the data by expressing information in form of terminologies or ontologies. Our SPHN toolset or ecosystem, as we call it, needs to facilitate the RDF data generation because actually nobody is really familiar with RDF data generation. So what we have is a terminology service in place that helps to bring in the terminologies that I was just presenting to you in terms of RDF, but also importantly with a view to versioning. Then we would, the projects have to basically generate a SPHN project specific ontology for their projects. And there we basically then have the data sources that, for example, our university hospitals that generate the data, the project data, and here we have some validation aspects that need to be taken into account, but also some statistic aspects that need to be taken into account. The project schema needs to be visualized in a way. So we have to come up with tools or helper tools for all of those steps, because this is not sort of a given that neither on the data providing side nor on the researcher side, people can do all of that by themselves. So this is basically what we call the SPHN schema forge. So this is the collection of tools that we have. For example, we have here the data set to RDF tool that generates an SPHN compliant RDF schema. Based on a data set input, we have the shuckler that extracts shuckle rules, we have the sparkler that extracts sparkle queries, and we have the visualization tool that generates a human readable HTML document from it. So this is now very new, and Sabine told me yesterday, I shouldn't say that it's already in production, but it's working. And if she says it's only beta, it's working better than most of the things. So this is our Schema Forge is a web service, right? So you do not need to implement now all of these tools individually, but you can use a web service for it. And the very fancy stuff now for our data providing institutions is the SPHN connector. The SPHN connector basically simplifies the process of connecting new data sources, new data providing institutions or hospitals to the SPHN ecosystem. So we also, of course, aim to onboard other hospitals than only the 5 university hospitals, but also for them, this tool is very helpful. It facilitates the creation of RDF data based on relational semantically described data in the hospital data platforms. There is an automatic format and quality checks possible, and this output can then be transformed, as I said, into other exchange formats anytime. And these presented features that the connector brings are, of course, crucial for hospitals with a view to efficient and also time efficient, but also cost efficient, sustainable data provisioning into the future, because this SPHN initiative will wind down at the end of 24. But we, of course, also on the long term would like our hospitals to be able to provide data for research project according to our interoperability strategy. So the challenges and the chances related to semantic web is really that it can do a lot, but only a few people, at least in the healthcare setting, are familiar yet with those standards and can write Sparkle or Shuckle. So we aim to offer here support with our tools. The semantic web standards are not common in healthcare. So when we look at the systems the IT systems that we have in the hospitals, we have missing expertise, of course, in the community, and there are always transformation efforts from those relational databases necessary. And of course, the handshake with other initiatives, but also other data sources is sometimes tricky if we want to include registry data or data from Federal Statistics Office. And there, of course, we have some problem when it comes to integrating new data types. On the other hand, we have many opportunities or advantages. So it is basically independent from particular data models. I already said that. It's flexible regarding data from different data sources, but also different types of data. And it has a high compliance with the FAIR criteria. if you look now at the data needs that we have, I showed you the first half of this diagram before. So basically, when we look to the opportunities, I was mainly only focusing here on precision health. But if you see now, when we treat the data at the source in a certain way, we of course have all of the other possibilities like the digital clinical trials, the hospital at home, and the pandemic surveillance and digital twins and virtual health coach and everything on the other side, because everybody needs the same data. We need high quality, structured and standardized data, no matter for what. And so this is, I think, a good reason for SPHN to invest really in this problem solving at the source or tackling the roots, rather than only coming up, I say only, this is not meant in a bad way, but only coming up with specific well-phenotyped data sets, because this is a sustainable and scalable solution that we would like to also successfully bring into the future. My take-home messages for you today are clearly: a research infrastructure initiative cannot possibly replace digital transformation in the healthcare sector. We learned that the hard way during the last 5 years. Of course, we are looking with a lot of envy to our Nordic countries, partners that have invested a lot into the digital transformation processes in their healthcare settings over the last 30 years. We clearly didn't. And now we have to bleed for it. So everyone wants high quality real world data from the clinic, but nobody really wants to pay for this. Everybody is shouting out loud that we should just share the data out of the hospitals. It's not a just sharing, it's a large investment into this data. And this costs money. And it's also not, let's say, sustainable if we just put one research infrastructure initiative on that for 8 years and then think the problem is solved. I would like to cite a nice sentence from Graham Greene that we heard from him in Montreux earlier last year. Standards don't send you money now, they send you money later. And of course, this is unfortunate but true. And we have to deal with it in a way that we have to convince all of our partners that standardizing efforts are worth it, because at the end, it will basically also yield in a higher efficiency. In tomorrow's learning healthcare system, we are at least convinced healthcare delivery and research must go hand in hand. We should not think about this in silos anymore. We need to converge and also really think of research approaches or secondary use approaches, to put it better, also when we think of how we capture data, how we treat data in hospitals, because there might be a lot more in for the hospitals than only the research part, right? The operational use requirements are vast. Fair data, and this is really the unfair thing about fair always benefits others, right? So for me, there is nothing in making my data fair. It's a lot of work, and many people of you know that very well in here. But we asked the question, how can we set the right incentives that it is not so unfair anymore? And of course, for this, for example, there's one reason why we have the funders around our table, because of course here we have leverage to also set those incentives correctly. A national data strategy, this is at least our opinion, is needed to achieve sustainable, scalable solutions for an efficient and responsible secondary use of health data. This just doesn't occur in itself as a coincidence, right? You need somebody who either pushes or pulls or does something, tells something. We need laws or ordinances that tell hospitals how exactly we would like to have the data, because this is a process that takes a lot of time. And if we do it correctly, and if we also join forces and not ask for 10,000 different types of data provisioning, but agree on a harmonized data provisioning, this would probably help to streamline a lot. And I'm pretty sure it's not all about the money. We can do a lot without a lot of investments if we only agree on a data strategy that makes sense. So with this, I would like to say a special thank you to Sabine and the data interoperability team of the Personalized Health Informatics Group. This is Christine Knotke, Jana Mida, Vasundra Touré, and Deepak Uni. I think most of them are also here today. We have other experts out of our network that contributed a lot to this verification efforts in SPHN, which I also would like to acknowledge here. And I would like to bring this to you. We are looking for a senior semantic data specialist currently in our team. So please, if you know somebody, help us promoting this. And with this, I would like to thank you for your attention.
Thank you very much for the impressive presentation. very impressive work. My name is Pantelis Natsiavas from Greece. I wanted to ask, I know that in Europe there are a number of initiatives working on similar subjects. I would mention indicatively the Eden project, which is an IMI-funded project, a very big project working on interoperability issues and observational studies and stuff like that. The other thing that comes to mind is the European Health Data Space Initiative. I wanted to ask if you are positioned, what's your position towards these initiatives, if there are plans to collaborate with them, because this, beyond policy, this also has implications in the technical level, in the interoperability level. I mean, they work with a data model called OMOP-CDM, for example. So this is why I'm asking.
So I don't know if I understand you, if I understood you correctly. So you're asking if we also collaborate with other initiatives internationally?
Yes, mostly focusing on Europe. This is I come from Greece, so I'm asking about the European.
So what we have some partners in Europe that we collaborate very extensively with. One of them is the Medical Informatics Initiative in Germany. It's not about the data sharing with them, right? It's about the methodologies. So we are in close collaboration with their semantic interoperability working group, with Sylvia Thun and all of her efforts around the FHIR. In Germany, we also have good collaborators in the Netherlands, for example, where we have already projects even. So it's a federated project, so it's not a data sharing, it's a visiting the data in the different countries. We are collaborating with the personal health train of the Netherlands, and we have some other initiatives and let's say efforts where we are sitting around the table in the realm of the European Commission or also the European Union. When you think of the 1+ million genome initiative and all of that, but truly sharing data now cross countries.
Nobody does.
Has not been done.
They don't share data even between them, but they follow another technical route. This is why I was asking.
Yeah,
this is why it came to mind.
Hi, I'm Phil Lord from Newcastle. You talked about the social problem of people being unwilling to or not necessarily having the resource to do all the FAIR and data release because they don't get any advantage for it up front, and then it's great later. There is the data is often that you're talking about is often perceived as very high value, and there's a lot of sort of big tech companies who are really interested in it, and probably when they do have the cash to pay for it. Do you think that's going to be a problem going into the future? Are you worried about sort of big tech coming along and saying, well, we'll pay for it all, and then we can do all of our machine learning on it, and then you might find that sort of public release of data gets more excluded from the picture?
I don't know. Do you understand the questions fine? I have really problems of understanding, but I'm just trying to repeat. So okay. You were asking if I think it's a problem that bigger players are coming, pay for the data. And
so there are a lot of big tech companies who are also interested in this data, and they have a lot more money than you do. So they could just buy it from your healthcare providers, and then you get cut out. So I'm wondering whether you worry about that.
Well, I worry about that on an ethical level. I don't worry about it on a economical level, because I think it would be good to have a little more money in the system, and also, help our healthcare providers to exploit this and benefit from that money. So in this regard, I think if it's done in a responsible way and in an ethical way, according to our laws, this is not the problem. I think the problem is really to see what we can do for our patients. We are working under a broad consent in Switzerland. It's important that we have the buy-in of the patients. At the moment, we sign a broad consent in Switzerland with the knowledge that this data can be shared also outside of the academic sector. So, and we have about 85% of people who are properly asked, they also sign this informed consent. So I don't know if they all understand what they are signing, but according to what is written, they know that this data can also be shared with pharma industry or other players. I think if it would be written there, Google and Amazon, maybe that would make a difference. I don't know, but I think it's in general not the problem. It's a problem of how it is then implemented, right, in terms of ethical and legal restrictions.
Thank you.
So I think really keep it very close to the mouth so that actually it's good to understand.
All right, like that? Yeah. So very quickly, if you were trying to do this in a larger country, what would you do differently? Would it scale up to a 10x population country?
You mean if we do this now in the States?
States, elsewhere in Europe, yeah.
Yeah. I think it's an excellent question. I think the fact that we are so close together helps, of course, with the motivation of the individual players, right? So if we would now stretch this over a country like Germany or the States, that might be more difficult to reach the people and to convince them of why we are doing this and why this makes sense. We saw that already in Switzerland, right? We had years of investing into explaining and motivating, and we finally really came to the point where we have now all of our partners really motivated because they understood the reason why we are putting such high efforts into the interoperability of data. I think in a bigger country, I mean, you can look to Germany. They also they have. I'm pretty sure they have more efforts in terms of reaching also the different areas or the more rural areas that we don't barely have in Switzerland. But I think in terms of time is, in this regard, time is on our side, right? Because this data, as I said, is needed for many, many different reasons. And as soon as, for example, a new law on cancer registration, cancer data registration comes, that asks from every healthcare provider that treats cancer patients of submitting the data in exactly this and this format over exactly this interface, they have to comply, right? And this is a synergistic effect. So you have not only the laws that require you to submit data into registries, but you also have the obligation to report to authorities and so on. So we have the many requirements for the same data. So I think it would scale to a bigger country, in case you also join forces, of course, with the government and everybody pulls on the same line. That would, I think, that would scale then too. But I'm not so sure with the RDF about this.
Thank you very much for your presentation. Actually, I mean, it's quite related to the previous question, but more at Switzerland side. I was wondering actually, what has been the main obstacle, or could be several on, to include actually the other dozen of hospitals that you have in Switzerland, actually, because I saw that we have these IV hospitals that makes part of the initiative. And also you are almost like at the end of, I mean, at least of the first phase of the project, if I understood well, to end in 24. And then I was wondering to know what's the main obstacle, like a technical, political, policy, or what's been the main thing that's impeding the adoption among all hospitals in Switzerland, actually? It's like technical?
No, technical is normally never the problem. I think it's the biggest problem when we started, and I think this is still true for the players that are outside of our network currently, is this cultural change, right? People in healthcare, at least in Switzerland, I don't know if this is very different in other countries, are not used to that thinking of, oh, we need to invest in our data because we want to do secondary usage of it afterwards, right? And so I think this is one of the main challenges that we had in terms of a cultural change of making people understand why these efforts are necessary and also worth it to do it. That's the one thing, because they have a very different mandate, right? They have the mandate for healthcare, not the mandate for producing high quality data. But it can go hand in hand. And I think the understanding that we have now in our community is that there is a positive effect on the quality of care if you take good care of your data. And I think this is really what we need to bring now also to the players that are currently still outside of our network. That is also not only us bringing this, right? They understand this from also many other sources. But the second thing is then, of course, a bit of a money problem, because you have to invest in new IT technologies in those hospitals. When you look at the data platforms, also this needs to be done, and this costs money. I think we have one estimate in Switzerland that coming up with a clinical data warehouse, as we had it, in the last years, it is about 500,000 francs a year that you have to invest in such a data structure. And this is basically not affordable or not argumentable for many of those smaller hospitals, because the revenue is not really clear for the CFO. So you need to come to that point, and this is where I said maybe it would not be so wrong to have a lot of other players in the field that also bring money into the system, to realize for those hospitals that a lot can be done with the data, and that will also, it will also benefit the quality of care for the patients, because then they invest in these kind of infrastructures and have a better data quality at the end.
I wanted to thank you as well for the presentation, and I actually have a question regarding granularity of data. Like, one of the beauty of RDF and semantics is I can absolutely encode everything. How far down that rabbit hole are you going? And is it still an ongoing discussion? Is it inspired maybe by use cases, questions you want to answer with the data?
I would like to give Sabine that question.
Yeah, as I think it is really use case driven. So we have actually, that was the slide which Katrin skipped. So we have now this national data stream. So these are 4 big 5 million projects, one on oncology, one on pediatrics, one on infectious diseases, and one on low value care. And these are really the main use cases which drive the concept development and the kind of how the concept should look like, which standards to be used. And there we do the kind of alignment. But as you said, we will never be able to, with one model, cover all the kind of use cases. And that's why we always allow that kind of extensions, which then again can be good or bad. They can be done in a semantically nice way or a bad way. So that is, again, we can provide guidelines here, but we don't have that under control. But we allow it to not actually include these projects. And I think that's really the kind of strategy which we try. So having a good defined core, providing guidance to extend, but in theory, you can extend in the whatever way you like. And we just look like that on some of the extensions. I think there was one more question in the front.
I just want to ask, you had at the beginning saying that the clinical data captured is mainly for the care person case, but it's not for the research in the first intent. So what type of data you think is still missing for the research case? Because I mean, that's quite a lot of stuff which you guys already collecting. But what have you experienced currently where you say this is something which would be very, very valuable for research, that it's there, or maybe brought in a, in a fashion that it can be used more, say, conveniently in the research context?
I actually see
it's quite a lot which you have already. I mean, it's impressive, lots of data.
Yeah, I see mainly 3 data types here. So one is really the data that is the information that is derived from the patient, right? So we try to bring patient-reported outcomes. You can think of PROMs, whatever you want, and or of PREMs. I don't know if this is really enough, but it goes in the right direction. It at least captures also the perspective, brings the perspective of the patient into this, because this is important and we need to do that more systematically. That is one thing. That is not the tricky thing. Well, not on the semantic side, on the technical side, but on other sides. The tricky side, on the more technical side, I see these are imaging data. So we have a lot of high valuable images around in our healthcare facilities. It's not so easy to get that prepared in a way that it is easily reusable, right? And I think in terms of multimodal data, also the genomic side that I mentioned. I mean, let's not start with omics. This is really either further beyond, but I think the omics, we need to come to a point where we have genomic medicine, at least, in our university hospitals, being a normal part of care. This is really just starting in Switzerland, and we are still doing panel sequencing for actually no good reason. Then only the reimbursement says we only can do panels, while the money would be sufficient for also doing whole genome analysis. So this is really something where we need to where we have this cultural change again, where we need to have pushes in terms of, these are not technical pushes. This is nothing that we can do in SPHN and say, now you look at the genomic data and please integrate it into our knowledge graph, and say, we don't have any. And so this is really, or let's say we don't have data that is really worth to invest in and share it, because it's there is not a lot out there. On one slide, you mentioned the importance of efforts regarding integration of omics data within SPHN. Are there future tasks or are they currently undertaken? I am particularly interested to know whether there are concrete things done on the integration of metabolomics data. What are the challenges? So I'm not a metabolomic data expert. I can't tell you the challenges exactly, but I can tell you that this has been, we are tackling this right now. And this is the slide that I skipped. We are basically currently setting up 4 national data streams, as we call them. So we are basically doing both, right? We're trying to work on the roots, but we are now also trying to come up with those highly phenotyped, specialized data sets. And these are our data streams, and they have basically as a mandatory requirement in our call setting, the integration of genomics at least, but also other omics data possible. And we have now 2 of them, as I recall, if I recall correctly, that integrate also metabolomic data. And this is done at a specific technology center here in Switzerland, in Zurich, where the data is pre-processed from an expert team, because this is then the collaboration, right? So they are partners on that national data stream, and they try to integrate also metabolomic data. I am pretty sure this is also done on the genomic side, but also on the transcriptomic side in many of those data streams. So we are slowly but surely getting those omics data into the knowledge graphs that we would like to see as the result, as the legacy, so to say, of SPHN coming out of this 8-year initiative, those 4 knowledge graphs of those data streams, aside from all of the efforts that we did together with the hospitals. But these will be the remaining fair data, hopefully, that can be then reused also by other researchers.
So I guess my question is closely related to the last question that was asked. I was just wondering if it's also part of your concern, if it also concerns you that these people that actually record the data at the hospitals use some standards so that the data that they input or record is standardized. And so there isn't the overhead of somebody actually taking the data, then standardizing it so that it's then usable at a larger scale. I'm not sure if my question is clear, but it means, I just mean, for example, if you have 2 different sources of data, like 2 different healthcare sources, and they will record data in their own standards,
Yep.
and these 2 standards might
Don't
not,
fit. Exactly.
be-
So this is why we have this interoperability framework, right, for all of the data providers that we are currently working with. So before I said we don't force them to share the data, this is true, but we force them to comply with our interoperability framework. So we tell them exactly how data should be standardized.
So you train them in some, I don't know.
Yeah, Sabine trains them. No, I mean, they have experts, but we are also putting efforts in training, but we are collaborating. So we have working groups, numerous of those over the past, where we really bring together experts from the different data providing institutions, looking at those aspects jointly, right? To bring everybody on the same level of information, on the same level of understanding. And this is the network effect that works now. We put a lot of effort in it. And this is also something that I think with the question to the scaling it up to bigger countries will create, of course, a problem when you have to bring so many people around one table to really understand. But I think also here we have technical means that can help with this, and we're getting better and better with it. And I'm pretty sure that also bigger countries would be able to manage to come up in a standardized way with those standardization efforts, because it's just a question of willingness.
Thank you. Just a comment. Any plan for considering any collaborations from the Middle East?
In terms of methodology or in terms of data sharing?
In terms of the data sharing.
So in terms of the data sharing, I might be skeptical, because we are not even sharing that, in the neighboring countries. So that might be tricky to send them abroad. But I think in terms of methodology, we are open for any collaboration with everybody.
Thank you very much.
Thank you, Katrin. Good afternoon. Good morning. Sorry. Question. You mentioned that you are 3/4 down the road of this initiative. What will happen afterwards? Where do you see the verification process? It's an ongoing process, in my opinion. Maybe you can share some thoughts on that.
Good question. So that was my concern over the last years. How do we bring this sustainably into the future? So we were working on a concept for our State Secretariat of Research and Innovation to present to them a following initiative. We know that they don't like this, right? They like initiatives that are closed and then they are over and then they can start new initiatives. So we didn't call it initiative. It's now something that is the data coordination center basically surviving into the new funding area of 25 to 28. And we presented them with the concept saying, okay, this is what we like to do. It's basically the work that we are already doing now, but on a national level, not only for SPHN, but also, for addressing other data providers, addressing other data sources, more closely collaborating with national registries or data collections from the Federal Statistics Office, for example, to bring this data coordination center to a level where there is one focal point in Switzerland that has the responsibility in terms of interoperability, of course, always in close collaboration with our e-health organization that is existing and other players. And this seems now quite successful. So we have a first draft of our next funding period that says we can go on with this work. We get probably enough funding for maintaining the DCC, the Data Coordination Center, but, and this is the important part, also funding to further subsidize the hospitals or the data providing institutions on the one hand side, because they have now built up capacity, hired a lot of people, trained the people, have excellent people working there. And it would be a shame if they would have to let them go only because they missed the funding from our side. So this is incorporated in that. Also on the other side, with regards to that secure compute network that we have built. Also here, everybody cries for IT security. Nobody wants to pay for it. We also put a budget post on our future budget for this to say we need to subsidize the maintenance and the operation of this network, because otherwise we don't have a place where we can put the data once we have it then. And it looks good. It looks promising that we will be further funded at least until 28.
Thank you. Happy to hear for you. Good stuff.